So the first specimen is coming from a 69-year-old female. This is her pleural effusion specimen, but her clinical history is a secant adenocarcinoma, so from the colon. So this is below diaphragm with a primary adenocarcinoma, and now you are seeing the pleural effusion specimen from above the diaphragm. So on low power view, we don't actually see like aggregates of cells. So they are not so prominent to cell population. But we do see like these loosely cohesive aggregates of a typical cell. So the cell indeed show increased size of the nucleus, and the chromatin pattern is quite irregular and vesicular. And a lot of these cells do have 1 to 2 like distinct nucleoli. And in focal area, we do see cytoplasm. It seems to have a vacuum in the cytoplasm. However, the arrangement is not typical for adenocarcinoma from the colon origin. And if we take a look of the background cells, so indeed we can appreciate that these cells does show a typical change because the size is much bigger than the background cells, and the chromatin pattern is also quite different from the background cell. So this is still suspicious for metastatic adenocarcinoma. So again, we see other cluster. These might be a lymphocyte overlapping, not the true nucleoli. But just in the background, we see very, very scattered. These are typical cells. Again, this one shows like overlapping. It's a little bit difficult to tell whether this is multinucleation or this is a glandular structure. So for these specimens, on high power, they do show scattered suspicious cells, but we are not very definite that this is indeed adenocarcinoma, particularly coming from the lower GI tract. So without immunohistochemistry, we might probably call these suspicious. This is the cell block preparation. In the cell block preparation, again, we see very similar cells. The amount of these typical cells is quite scant, and they do not forming a nice tight aggregate. But you can appreciate that the nuclear, the shape of nuclear is very strange, cytoplasmic vacuole, eccentric nucleus, and it is more hyperchromatic and with an irregular chromatin pattern. So we seem to have some scattered typical cells as well in the cell block preparation. So that's why we can do a immuno to confirm whether these are true metastatic tumor cells. So the choices of immunostains include, this is MOC31, which is a nice glandular marker that can highlight glandular cells. So in the effusion cytology, supposedly there should be no glandular cell, but here we see in a very similar pattern, just scattered single cells or like a few cells in cluster. And these cells indeed are much bigger than the adjacent normal cell. So these are positive for adenocarcinoma. And we also do a lineage-specific marker to confirm. So we use CDX2, which is a transcriptional factor for lower GI tract mucosal epithelial cells. So these also show similar pattern to the MOC31. So we confirm that it does show metastatic adenocarcinoma, and it is consistent with the patient's non-history of colon cancer. So we sign this out as positive. So in the situation, particularly across the diaphragm and with very scant tumor cells, sometimes we will want to use the immuno to confirm. And this is the patient's first specimen to show that it's already across diaphragm metastasis in the pleura effusion. So the next specimen is coming from a 71-year-old male, so very old, and this is also pleura effusion. So he came to our hospital as a fresh patient, so without any history. By clinical evaluation, they find to have a lung mass. So they think this is primary lung cancer and with pleura effusion spreading. So on low power, again, we do not see quite prominent like aggregates of tumor cell everywhere, but here we do see some aggregates of the cells. And these cells does show much typical morphological pattern of adenocarcinoma compared to the prior case. So very big nucleus, irregular chromatin, some nucleoli, and prominent pleomorphism. So just in one cluster, you can appreciate much smaller nuclear, much bigger nucleus, and the differences is above like a 1:4 ratio. And also, it shows like a quite like a three-dimensional architecture. So you really need to focus up and down to see everything. So this is quite common that we will see in the primary lung adenocarcinoma with this type of presentation. So this is most favored as a primary lung adenocarcinoma. In the cell block preparation, we also see similar finding as these adenocarcinoma cells arranged in this tight glandular pattern. So again, prominent pleomorphism, prominent nucleoli, and arranged in a tight cluster with bubbly cytoplasm. So we can do a TTF1 to confirm that this is coming from the lung, and the clinician can use the specimen to do molecular testing. So this is positive for lung adenocarcinoma. So next specimen is coming from a 63-year-old female and who presented with thyroid nodule. So they perform a fine needle aspiration of thyroid. So low power is important. On low power, it is hypercellular, but we do not see any colloid. So that is an unusual pattern. Additionally, the architecture pattern is also quite interesting because it shows very prominent, delicate branching papillary structure. So with this papillary structure, we might think, could it be papillary thyroid carcinoma? But now we are quite experienced with this type of lesion. When we go to higher power, all of these cells show very round, uniform nucleus without oval change, without nuclear inclusion. And we do see prominent vasculature. So this is a transgressing capillary, like going through this cluster of cells. So morphologically, this is a typical parathyroid lesion. So again, you can see this is a capillary and it goes through this cluster of cells, and most of the cells show very tight like round cell uniform and with condensed chromatin. So based on the cytomorphology alone, these may look like follicular cells. However, it does not show typical follicular cell arrangement, which is usually presenting as a flattened sheet of honeycombing that is reflect the morphologic cytomorphology of a macro follicle. So when the macro follicle aspirate and the big follicle will have a very flattened sheets of cell. But here we see these tight papillary aggregates and the cells are packing in a very tight cluster with three-dimensional architecture. This is very unusual in the thyroid follicular lesion. So if we find that this is a parathyroid lesion, usually we will go back to the history. There were two scenarios. The most common scenario is whether this patient has chronic kidney failure and is under hemodialysis. So this would reflect secondary parathyroid hyperplasia. So indeed, the patient has SLE and already under hemodialysis for many years, so this is actually not a thyroid lesion. The clinically, they think this is a thyroid lesion, but this is actually consistent with parathyroid hyperplasia and secondary based on the clinical finding. So this is the direct smear. Again, you can see these very complex delicate papillary structure, and the background is very clean, no colloid at all. So this is a typical case of parathyroid lesion, and based on the clinical information, the most likely is the secondary hyperplasia. So we will use the residual liquid-based cytology specimen to perform. We will use GATA3 and the parathyroid hormone for confirmation that this is parathyroid origin. So the next specimen is also a thyroid specimen. So background, no colloid. We start to see like a very, very scant colloid, so which means that we are in the thyroid, so it's okay. Some blood, and this is a paucicellular specimen. So for a paucicellular specimen, we just need to go to each cell cluster that we identify to see if there are any atypical feature. So for this cluster, the cell, you can appreciate that it does show focal overchange, and the cell looks quite different by size or by shape with the adjacent cell. So we start to identify some nuclear atypia. And additionally, we do see a pseudo inclusion over here. So there is intranuclear pseudo inclusion, and they are more. And so one pseudo inclusion over here, and another pseudo inclusion over here. So basically, these, just by structure, these looks like what I call the decapitated papilla, right? So you see the luminal border on three different sides, and this one is blunted. So this is actually a papillary structure. So this is the single cell cluster in the our aspiration specimen for the liquid-based preparation. So we only see a single cluster of follicular cell arranged in a decapitated papilla, and we also see 3 intranuclear inclusion. So this is the direct smear. So for the direct smear, it is not very easy to see through, because the cell seems to be in a clot. And I think most of the cells here is actually looking quite bland looking because this is rounded and without irregularity, forming like a small follicular type of pattern in a clot. So the cell here is actually look very benign. We do not appreciate any atypical finding. So I go to the sonography. So the lesion is very, very tiny. It's only 3 millimeter. So it suggests that it is a very tiny hypoechoic nodule with irregular margin. But you can imagine that must be really difficult to sample the lesion. So in the direct smear, we do not get the tumor cells, but in the liquid base, they does show quite prominent feature of PTC. So in this case, I decide to call the directly PTC. You can choose either suspicious for PTC category 5 or directly call this PTC based on your confidence level. I think for this lesion, because I checked the sono is very typical for PTC despite the small size. And here we do see papillary structure and the 3 inclusion. So I think, yeah, maybe we can just call this PTC. So finally, I decided to call this PTC. So another specimen, we only have direct smear for this specimen from thyroid again. So low power, we see mostly blood, and it's relatively paucicellular. So because it is a direct smear, it's kind of easy to have drying artifact for alcohol fixed slide. But here we can see a very big cluster of cells and with a pseudo inclusion over here. So again, this is a paucicellular specimen. We only have a very, very scattered, well visualized cell cluster and showing a typical feature. So that's it. Okay, so these specimen I decided to call these suspicious for PTC because it shows drying artifact. And yeah, this is because this is coming, we don't have, I don't have a sonograph for this case. So I just call these suspicious. So based on the cellularity and different confidence level and by the clinical feature, if you have the correlation, we will have a different threshold for calling indeterminate diagnosis. So the next specimen is coming from a breast aspiration of a 53-year-old female. So this is coming from the breast. Quite hypercellular, a lot of cell cluster. So we just need to go to high power to check. So on high power, this cell cluster does show very prominent nuclear atypia. You see gigantic cherry red nucleoli, and the shape of the cell is quite polymorphic. And we also have some spindle-looking cells. So this is consistent with carcinoma, likely a ductal origin. So with these high-grade nuclear type of atypia. In cytology, it is relatively difficult to distinguish whether these are coming from an in situ DCIS or this is coming from an invasive ductal carcinoma. Sometimes it's not very easy. Sometimes we can see some small, like attenuated myoepithelial cells in the cell cluster. But for this case, it's very difficult to appreciate. So we call this carcinoma. However, the corresponding biopsy shows mostly DCIS. So in this cluster, you can see there are like a smaller, more condensed cells in the periphery, some with an oval shape feature. This is actually a myoepithelial cell. So for this cluster, we do see very scant myoepithelial cell around the cell cluster. But usually we cannot make distinction whether this is a DCIS or this is a invasive ductal carcinoma. So next specimen, 74-year-old female, neck lymph node. So she came to our ENT department due to enlarge of the neck mass. So low power, this is a lymph node, but we do not see lymphoid tissue in the background. So mostly like a cellular cluster. Just on low power, we can appreciate that the size of the cells are very, very big. They are gigantic cells. So go to high power. Indeed, the cells are very big, arranged in tight cluster. So here we start to appreciate that they are glandular arrangement with intracytoplasmic vacuole. So this looks like metastatic adenocarcinoma. So with this morphology, if you put the tumor cell into, for example, pleura effusion, this looks like primary lung cancer. And again, lung cancer is the most common cancer now in Taiwan. So for this case, I think the first consideration is this is coming from the lung. So we will do a TTF1. And this is the TTF1 immunohistochemistry. So this is positive for TTF1. So this is a metastatic lung adenocarcinoma with positive TTF1. 谁可以借我一支笔？有吗？有笔吗？没笔。谢谢。Yeah, so this is TTF1 positive. Okay. So finally, we have a correlation case. So this is a parotid gland, submandibular gland aspiration. So the clinicians suspect they are there is a nodular lesion in the submandibular gland, and this is the fine needle aspiration. So low power, very clean. We only have a small cluster of cells. So mostly arranged in these like rounded cluster. And the cells does show relatively prominent cytoplasm with a granular cyanophilic feature. The nucleus are very uniform and looking like a low-grade epithelium. So again, we see these tight, like a cluster, a little bit like a ductal cluster, but the cell does show some cyanophilic cytoplasm with a feature of oncocyte. So not much, so basically very similar, small tubular structure with oncocytic like a cytoplasm. In the direct smear, again, very similar feature. So here we have a non-neoplastic acinar cluster. So this is non-neoplastic. But this cluster of cells seems to be a bigger sheets-like pattern and with a difference in the cytoplasm. So here is more like a loose and light and much granular, and this is more dense. So this is looking more like an oncocytic epithelium. So because clinically they suggest that there is a nodular lesion, and I think the lesional cell looks like this. Mostly oncocytic, low grade, very bland looking. Again, looks like this. So we call these salivary gland neoplasm of uncertain malignant potential and suggest the cellular morphology showing oncocytic feature. So after that, the clinician actually do the submandibular gland excision. It's actually a non-neoplastic lesion. So the nodule, do you see there are dilatation of the salivary duct? And there were atrophy of the salivary gland. This is relatively normal. So it's actually showing a regional like atrophy, likely due to obstruction of the branch of the salivary duct, and induce this type of nodular atrophy pattern. So when we go to higher power, so the oncocytic cell is actually possibly the interdigitating like a ductal epithelium or like much smaller ductal epithelium. In the cluster, we have very scant acinar cells because it's atrophy. So going back with the histologic correlation, these are actually atrophic ductal epithelium, not neoplastic, and maybe the background show a little bit lymphocyte with this crashing artifact. So going back, this is if we want to call these, I think it's also relatively difficult to directly call this non-neoplastic because we do not see a lot of inflammatory cell in the background. So maybe the best diagnosis would be AUS because AUS is used in the situation that we cannot distinguish whether this is a neoplastic lesion or this is a non-neoplastic lesion with reactive change. We will use the AUS diagnosis. So maybe the next time for this type of specimen, we will try to call these AUS instead to call these salivary gland neoplasm of uncertain malignant potential. However, it's also the clinician also need to like share some responsibility because if the image does show dilated duct, they should think about this is an obstruction lesion instead of like a falsely refer this is a tumor nodular lesion and do the finding the aspiration. Yeah. So in some clinician, this is actually coming from one of the more problematic clinician that he will sometimes make like a not accurate clinical judgment. So sometimes we will have some problem. Yeah. So finally, this is one case that has been like a annoying like a trouble for 2 or 3 weeks. So we have a patient with ascites specimen showing these prominent like individual cell correlations that the cells are very big and atypical. So this is a case of lymphoma and with unusual necrosis pattern. So we check the clinical history that the patient has received steroid. So this is common in the post-steroid treatment in the lymphoma case, but the patient do have a very high disease burden of the lymphoma in the ascites fluid, and the biopsy confirmed that this is actually a Burkitt lymphoma. So we see uh, actually first off another patient's thyroid aspiration. So this is indeed from thyroid because we do see colloid. So this is coming from the thyroid. So I see this specimen first. We see colloid, it's in the thyroid. But in the background, it shows like a prominent individual big cell with necrosis. So this looks like lymphoma. We rarely make diagnosis of lymphoma in the thyroid. This is benign follicular cell. So we see benign follicular cell, we see colloid, and then we see this type of cell. So that is relatively unusual, but just based on the cytology, it's quite definite that this is a lymphoma. So I was going to call this lymphoma, and then I see on the same day, we see ascites specimen, and they look the same. So I know that these must be coming from the same patient, so these must be a contamination. Additionally, for the direct smear of the thyroid aspiration, we do not see any lymphoma cells. We only see the colloid, so this looks like a benign nodular goiter. And we also see benign looking follicular cells. However, the lab told me that these are coming from like two different shipping of specimen, and they perform the preparation at a different time. And one is coming from the outpatient, the other is coming from the inpatient, so there is no way that clinically they can mix the specimen together. So it was a very unusual situation. For the thyroid specimen, I asked for the repeats, and I also asked for the CD20 and CD3. So again, in the thyroid residual liquid-based cytology, it is diffusely positive for CD20. So this is a B-cell lymphoma, aggressive B-cell lymphoma for sure. And so we keep going back to see whether is any like a possibility that we can mix the specimen. And so the lab did not find any chance. So I decided that we should do a genotyping. So we used the maternal test genotyping here. And the thyroid aspiration is coming from a female, but the ascites is coming from a male. So we do the paternal like a testing for the microsatellite as well as the sex chromosome. And then it turned out that in the thyroid aspiration specimen, it has a Y chromosome. So that is a proof that the specimen is not coming from the female patient, and this is coming from the male patient, and with identical microsatellite like a pattern. So this is definitely mixed specimen, and so we check the camera again and finally find the issue that we might like mix the specimen because of the deposition basket looks very similar, and they deposit the droplet to the deposition basket, but it's very similar to the one which is not a deposit, so they reuse it again, and it happens to be this specimen. But because I already know it must be the contamination, so I already signed the thyroid specimen as negative follicular nodular disease like 2 weeks ago, and then it proved that I'm right, that this is definitely a contamination. So occasionally, in a very large lab like we have a very high volume of specimens, sometimes it is not easy to avoid contamination, whether these can coming from the staining, from the fixation in the fixation alcohol tank, or from the staining like an automatic staining machine, or from the preparation. So there are multiple steps. They may have a chance to mix the specimen. So we must identify which step that we are doing it wrong. So now the lab already think about something to make distinction of deposition basket or the new basket. So these must to be in two different color and putting in a two different location. So the next time we can avoid this problem. Yeah. Okay. So thank you very much.